We also, over the last month, had release of our genetics familial, colorectal, endometrial, and gastric cancer NCCN guidelines. So again, those were released on June 13th. So I wanted to provide some highlights. This is by no means comprehensive, but I just pulled out some of the updates. And what I've done is I've put the page numbers per the NCCN guidelines, but also on the PDF, it's page 50, because I find that sometimes these guidelines are kind of hard to navigate. Now, with MSH2 and EpCAM, there was a row on sarcomas added based on recent publications. And again, there are some risk estimates. At this point, there's no clear evidence to support surveillance. So again, that is outlined in the guidelines at this point, but this was a new change. PMS2 was greatly abbreviated in terms of cancer risks. So there were multiple cancers that were removed. And basically, it was replaced with, well, Lynch syndrome associated cancers have been observed in individuals with PMS2 Lynch syndrome. It is unclear whether PMS2 Lynch syndrome carriers have increased risk for these cancers. So again, I would check that out. That was, a fairly substantial change there. Looking at surgical options and individualizing care for Lynch carriers. What was stated, this is on page 65, account for genotype, phenotype, family history, and personal considerations. For example, extended colectomy may be more favorably considered for individuals with higher risk genotypes, so the MLH1, MSH2 carriers, or a stronger family history of colorectal cancer, Lynch syndrome associated. And then segmental resection, again, lower risk genotypes was kind of the general guidance that was given. Moving on, Poitsier syndrome, there were some diagnostic criteria that were updated, so I would check those out as well. For CDH1, for stomach cancer, now limited to diffuse in the table. Signet ring was removed, and the reason for that, as all of you or many of you know, is that that feature, the signet ring feature, is pretty much present in all patients. And again, some updated risk estimates were provided for both stomach cancer as well as lobular cancer. And then again, the importance of sending to an expert center was also highlighted in these guidelines. With NTHL1, what they indicated for duodenal cancer, baseline upper endoscopy, and then what I found interesting, I wasn't familiar with this data, heterozygote cancer risks are unclear, but have been observed. So again, there's not any definitive data at this point, so nothing changes, but this is, again, something to keep our eyes on. And then TP53, colon cancer risks were updated. They were actually changed from greater than 20% to 5 to 20%. So that is a change. And then the age used to be 25 years, but it was changed to 20 to 25 to give more wiggle room. Now, two other things I wanted to mention. There was a panel, because there have been a lot of changes to both the KEG and the BOP guidelines over the past year. So there was a session that I moderated at the annual NCCN guidelines meeting, and there is a paper, kind of a highlights paper that was published. And again, you can see this, we had some great speakers that commented on the prostate cancer updates, endometrial cancer updates, gastric cancer, as well as the genetic counseling perspectives. The link is available that we can send out. And the session, I was surprised, is also available for listening to in case anyone is interested. And it's free. It's, I think, available up until March.